Thank you, Tanya. And hello, everyone. I'm just going to jump right in. My name is Marlee Adams, and this is my thesis presentation. My project is titled Identification and Care of the Person with Bipolar Disorder in a Community Midwifery Setting. Great. So here's just the agenda. Basically, I want to start with some definitions, go through what I did in my thesis, which includes a literature review, a survey, and a curriculum, as well as reflecting on the strengths and weaknesses of this project, going through a case study that I created for the curriculum, and just talking about how we move forward after this. Before I continue, I just want to say thank you to my committee members, Dr. Amrita Bhatt and Lori Ganberg, as well as my committee chair, Dr. Tanya Taiwo. I'm very grateful. You all have been so helpful, and I truly could not have done this without you. So thank you guys. Great. So one last thing before I truly get into this presentation, I first wanted to just make a note about gendered language and research. Really all of the research I looked at used terms like women and mother, and while that does describe many birthing people, it doesn't describe all of them. There are non-binary and transgender people who give birth, and I think it's important that in the future we include them in our research populations by trying to use more non-gender terms. The other thing about perinatal research is that it's quite difficult to conduct because pregnant people are a vulnerable population. And so it can be really hard to accurately study it, especially to control for things like medication use or substance use. And that's something that I'll talk about a little bit more later on. But let's get into it. So we'll start with some definitions just so everyone can kind of be on the same page. Depression is the one that I think most of us are most familiar with. It is a mood or a mood disorder that is associated with things like sadness, lethargy, loss of interest or pleasure, decreased concentration, and in some cases, suicidal ideation or intent. Now, bipolar disorder does involve depression, but it also involves mania or hypomania. So it's a mood disorder characterized by both ends of the mood spectrum. Mania and hypomania are quite similar. They both involve an elevated or irritable mood, increase in energy, lack of impulse control, and typically difficulty sleeping as well. They both impact day-to-day functioning, but mania is typically more severe than hypomania. To give you an example, someone in a manic episode might have impulse control difficulties that result in them gambling all of their money away, while someone in a hypomanic episode may have similar difficulties with money management, but spends maybe thousands of dollars, but not depletes all of their money, if that makes sense. The other thing to note is that people can actually have what's called a mixed state, which is when they experience both depressive and manic or hypomanic symptoms at once, which can be very confusing clinically. Mania is associated with type 1 bipolar disorder, while hypomania is associated with type 2. They're just different classifications. And finally, psychosis is a psychiatric emergency associated with mania, and it can involve things like delusions, paranoia, agitation, cognitive disorganization, and hallucinations. This is also something I'll be talking about a little bit more later on because it's quite important. So jumping into my literature review, I think it's important to note that up to 4.4% of people have bipolar disorder. So this is something that midwives are going to be running into, whether we know it or not. Even just going to the grocery store or the movie theater, you're likely going to be running into people who have bipolar disorder. The postpartum period is the highest lifetime risk for having an episode or a relapse. So that's really important for midwives to note, is that's when our bipolar clients are at the highest risk, and we really need to be paying attention to them, as well as just screening people who are showing symptoms of depression at that point. So it does develop from genetics or experiencing highly stressful life events like sexual assault, for example. So it's not something that we can prevent as much as we can treat and prevent further episodes by providing treatment. So a bipolar depressive episode is what we call clinically indistinguishable from a non-bipolar depressive episode, meaning someone who is bipolar and is feeling depressed and someone who has major depressive disorder or postpartum depression, you can't tell the difference unless you do screening. And this is really important because of the different ways that we have to manage these different disorders. So if you don't screen, you don't know. Almost 23% of people who screened positive on the Edinburgh postnatal depression screening tool actually had bipolar disorder, meaning that quite a lot of people who screened positive for depression did not actually have true unipolar depression. And this rate went up even higher when the people had a higher score on the depression screening. So for midwives, it's important to know when someone's a score on the EPDS, they are slightly likely to have bipolar disorder than someone who did not. So just to speak briefly to the risks of relapse, this is something I could talk about quite a bit, but the relapse rates do vary depending on if someone stays on medication or discontinues them or weren't on them at all. Relapse rates are high in general, but people who discontinue their medication in pregnancy or postpartum have up to 100% chance of having an episode, while people who stay on their medication have up to a 45% risk of having an episode. So while that number is still high, it is significantly decreased from the people who are discontinuing their medication in the perinatal period. Notably, 60% of people who had an episode sometime in their pregnancy also had an episode postpartum. So this is another thing for midwives to keep on our radar. If you have someone who has a depressive, manic or hypomanic, or even a mixed state prenatally, they have a 60% chance statistically of having a postpartum episode. And the highest risk of having this postpartum episode is in the first 6 weeks postpartum. This is when clients are still in community midwifery care, which is another reason why it's so important that we're being vigilant about this, because we are primary care providers at that point in time. So now I'd just like to speak briefly about the risks of bipolar disorder. There are significant potential risks to both the parent and the baby. The two words we have in green here, I'll kind of come back to. But for the parent, some of the risks include induction of labor, cesarean birth, hypertensive disorders, self-harm, suicide, psychosis, and impacts to the bond between the parent and the child. For the child, there are risks of things like congenital anomalies, being born small for their age or of a low birth weight, being born preterm, having seizures, or even infanticide, which is when the parent kills their baby. So these two items in green here, gestational diabetes and congenital anomalies, there's been some debate about, which I do want to briefly discuss. Gestational diabetes is caused by metabolic changes from the placenta, but it gets kind of confusing in bipolar research because many of the medications that are prescribed for bipolar disorder actually have metabolic impacts. And so it's unclear if these medications are what's increasing the risk of gestational diabetes, or if bipolar alone, regardless of medication status, is increasing this risk. It's basically the same thing for the congenital anomalies. It's unclear if bipolar alone is causing an increased rate or if it's just the medications, because we do know that some of the medications are associated with increased risks of congenital anomalies. And that is also something I'll talk about a little bit more later. The last thing I want to say about this is again about postpartum psychosis. 2 per 1,000 people will experience it, and it can be the only clinical manifestation of bipolar disorder if you don't screen someone. So they can go through their pregnancy perfectly fine, some of their postpartum perfectly fine, and then boom, someone's in a full-blown psychotic episode, and maybe we could have caught that if we screened them. So speaking of screening, time to talk about our screening tools. So these are the most commonly used ones for depression. First, we have the Edinburgh Postnatal Depression Screening, the one I briefly mentioned before. This one is nice because it's widely used and recognized, and it's validated in the perinatal period. But the drawbacks is that it doesn't assess for any bodily symptoms of depression like fatigue or lethargy, and it's not screening for mania or hypomania. The PHQ, the Patient Health Questionnaire, is also widely used and recognized and validated. And I like that it asks about the bodily symptoms of depression. The catch-22 about asking about those things is that some of those bodily symptoms can just be attributed to normal pregnancy and postpartum. For example, someone who's pregnant could very normally be tired, especially someone who has a newborn. You expect them to be tired, they're up all night. So that can just kind of confuse the screen, and it's something to keep in mind. And again, the PHQ doesn't screen for mania or hypomania. So moving on to the bipolar screening tools, we have first the Mood Disorder Questionnaire. This one is considered the gold standard of bipolar disorder screening, and it has a high negative predictive value. This means when someone gets a negative screen, it is most likely truly a negative screen. The other nice thing about this is it's better at identifying bipolar disorder type 2 and other more ambiguous forms. So that was the one associated with the hypomania. The drawbacks of the MDQ is that it has a low positive predictive value, which means that only about 50% of the people who get a positive screen on this actually have bipolar disorder. And it's actually not effective if someone is already diagnosed with it because it's a historical screen. It doesn't ask about current symptoms, and so it can't assess if someone is currently having a hypomanic or manic episode. Which is why I like the PMQ. It actually assesses for hypomania, and it's a unique tool. It's meant to be used in the moment, and it was actually created to be paired with the PHQ, the depression screening we just chatted about, to truly rule out depression versus bipolar disorder. Really, the major drawback of this is that it's a newer screening tool, and so it's not been validated yet in the perinatal population. So this is an image of the Mood Disorder Questionnaire. I wanted to show this because we actually administer it a little bit differently to pregnant and postpartum people. Research has shown that it has better sensitivity and specificity if we take out these 2 questions with arrows next to them, number 2 and 3. So if you're a midwife administering this screening tool, just make sure you scratch those out and don't include those in the total score. And a positive screen on this is considered saying yes to 7 or more items in box 1. So this is a table I created for my project about different organizations' screening guidelines and recommendations. Basically, the overall of this is that they're not great. There's not a lot of clarity or agreement between when we should be screening or with what. Some of them are more ambiguous than others. For example, the National Institute of Clinical Excellence only says to screen at some point prenatally. They don't specify about postpartum screening, and they don't even say what tool to use. Similarly, at the bottom here, the USPSTF says screen in pregnancy, screen postpartum, and again, they don't care what tool you use. Um, I like the APA's one, the American Psychiatric Association's, a little bit better, actually quite a bit. It says to screen once in early pregnancy and once in late pregnancy. So that's nice. You have a good baseline. And at each pediatric visit in the 6 months postpartum. They don't say what tool to use, and bipolar disorder isn't mentioned as one of the things you should screen for. ACOG doesn't specifically say to screen prenatally, but they do say to screen postpartum, and they recommend screening for depression and anxiety, but not bipolar disorder. The last guideline here is from 2 organizations, the Canadian Network for Mood and Anxiety Treatments, as well as the International Society for Bipolar Disorders. They recommend screening once prenatally and once postpartum, but only if the person is showing symptoms of depression. So I like the recommendation to screen once prenatally and postpartum, but I don't like that it says only if you show symptoms of depression. People might not report they're feeling depressed. They might not show it to their midwife in their 30-minute or less visit. And it's not screening for mania that way or hypomania. People who are manic or hypomanic often feel good. They have an elevated mood. They're not needing to sleep as much. They feel great. They're not going to complain about it. It's going to be friends or family or care providers who notice it. And if we're not screening or spending the time with them to assess for it, then we don't know. The other thing I like about this recommendation, though, is that it does recommend using the MDQ. So this is the only guideline here that recommends using a bipolar screening tool, which I appreciate. Okay, so now just to talk about midwifery education. Only 20% of perinatal care providers are routinely screening for mood disorders. And I will explain why in a minute here, but it's really unfortunate that the number is so low. I just wish we were doing better overall, and hopefully that can change. Research has shown that midwives don't receive very good training about perinatal mood disorders in general, and they report feeling uncomfortable caring for people affected by them, which makes sense. You don't know about it, so you don't feel comfortable managing it. Despite this, most midwives do want to be better educated about perinatal bipolar disorder. And when they did feel well educated, they were more likely to participate in routine screening. So when we make sure midwives are educated about these issues, they will adhere to the screening guidelines recommended. Unfortunately, though, midwives were found to be less likely to screen if the situation was challenging. So if there was a language barrier, if the provider and client were not culturally matched, or if the partner was present. So I think that's just a moment to reflect on cultural humility and competency, and just ensure that we as healthcare providers are ensuring that we're checking our biases and really doing our best to provide the same quality care to all of our clients, regardless of whether our backgrounds are the same as them or not. Okay, so now to speak about bias in midwifery. Studies have shown that patients or clients have reported that their midwife's demeanor changed after they disclosed a mental health diagnosis to them, and not necessarily for the better. In one study in Ireland, almost 20% of midwives stated that mentally ill people are dangerous, and 50% said that the public needed to be protected from those who are severely mentally ill. I think this really speaks to the stigma, which is probably largely caused from a lack of education. But I think it's important in this sense to also really reflect on, are people who are mentally ill crazy? No. And saying things like, this person is being so bipolar right now, the weather's so bipolar today. That sort of thing really contributes to the stigma. So I encourage all of you to really be thoughtful about the language that you're using in your day-to-day to reduce stigma about mental health. So getting back into it, midwives also reported feeling overwhelmed at the severity of information disclosed about person's mental health history. which again makes sense considering the lack of education. And actually, one study found that 30% of people did not disclose any of their mental health history to their perinatal care provider, while another 20% only disclosed some of it. So in the study, 50% of people with some sort of significant mental health history did not feel comfortable sharing all of it or some of it with their perinatal care provider, which is just really unfortunate. So again, decreasing the stigma and fostering an environment where people feel like they can be honest with us about it really allows us to provide the best care for them. So just to wrap up the literature review here, I wanted to speak about treatment. There could be a 4 to 6 hour webinar just on this topic alone. And since medication management for mood disorders is not in the midwifery scope of care, I'm going to keep it brief. So bipolar disorder is a neuroprogressive disease, which means that if left untreated, it actually will get worse. For this reason, pharmacotherapy, medication management, is the gold standard recommendation of bipolar disorder treatment. This is something that we really have to encourage our clients to do, but also listen to them and provide client-centered care. Many people don't feel comfortable taking medication in pregnancy or postpartum, and we do have to hear them on that, and also make sure that they have all the information so that they can truly make an informed choice, whatever that be. And so by knowing at least a little bit about these treatments and what's safe and what's not, we can help them navigate that choice. Prescribing antidepressants alone, antidepressant monotherapy, is contraindicated for people with bipolar disorder. This is because if you give someone with bipolar disorder just an unregulated antidepressant, their mood just goes up, 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 and there's nothing to kind of regulate it back down or keep an equilibrium. Unfortunately, one study found that 42% of OBs were prescribing antidepressant monotherapy to their bipolar clients, and another 42% weren't treating them at all. Both of these things not recommended. There are 2 medications to avoid in pregnancy because of the risk of congenital anomalies. These are sodium valproate and carbamazepine. Lithium is considered fine for pregnancy with some monitoring, but it is essentially contraindicated while breastfeeding. The other thing about medication management is that the plasma volume, the blood volume in pregnancy increases quite significantly. And so it actually makes it more difficult to keep someone stable. They have a certain percentage titer of medication in their blood, but as that blood volume increases, it of course is diluting the amount of medication in their bloodstream. And this can cause episodes and that sort of thing because the person is no longer at a therapeutic dose. So I'm going to touch briefly on non-pharmacological treatments here. This one is a little tricky to talk about, but it was one of the most requested things from midwives in the survey I conducted, so we shall speak about it. There really has been little to no research about the safety and efficacy of non-pharmacological treatment for bipolar disorder in general, but especially in the perinatal population. But something to note is that, like antidepressants, mood elevating supplements or herbs carry the risk of inducing manic symptoms. So whether it's antidepressants or mood elevating supplements, we have to be careful. And again, this is why screening is so important, because if you recommend an antidepressant or an herb to someone who you think just has depression, but they had bipolar disorder and you didn't check, you can send them into a hypomanic or manic episode. So some of the herbs or supplements that I saw maybe 1 or 2 studies about each were fish oil, ashwagandha, CoQ10, pregnenolone, and bright light therapy. Another thing to encourage you to research before recommending is that bright light therapy is recommended to be done differently in people with bipolar disorder than people with major depressive disorder or postpartum depression. So someone with bipolar disorder should do bright light therapy midday at a lower lux than someone with depression, and that's something to note. Now for mania, that one's a little bit trickier to target. Sleep is really one of the best, if only true remedies. Pharmacological sleep aids are going to be much more effective than over-the-counter herbals or homeopathics, but some of the ones that I saw looked at were Calms Forte, chamomile, unisom, and magnesium. If I was going to suggest any of those, it would be unisom, but I still recommend that your bipolar clients are seeing a perinatal psychiatrist who can help them navigate this and get them medication prescribed if that's what they need. Again, if you are going to recommend herbs, do your research, but definitely don't recommend St. John's wort or ginseng. They have both been shown to induce mania in multiple case studies. So it's important that we do not use those herbs for our clients with bipolar disorder. Something called electroconvulsive therapy, ECT, has been studied in pregnancy and is thought to be safe by ACOG and AAP, but it should only be used in treatment-resistant people or those with severe cases, and someone having ECT likely may not be in our care. I found one systematic review on it, and 4 out of 5 studies that they looked at found it to be acceptably safe, with the 5th finding it not safe at all. Although the 5th one was pretty biased research because it included poor outcomes like stillbirth that weren't actually related to the ECT. So not really a fair study. And then finally, counseling and therapy are really great and important measures for people with bipolar disorder, as well as a good support system. Research has actually shown that being stable and having a good support system reduces someone's risk of having an episode. So that could be economic stability, housing stability, and having partners, friends, family who this person can lean on. So if our clients don't have those tools or resources, we can help them find them and hook them up with people in the community and organizations in the community who can get them what they need so they can be as stable as they can to minimize the risk of an episode. Okay, so now just to chat about my survey. I distribute it via social media. I put it in a couple of midwives only Facebook groups. And I also emailed the survey to at least one midwife from every practice in the Midwives Association of Washington State database, which took a lot longer than I thought it would. But all in all, 58 people completed the survey in its entirety. And these are kind of the broader conclusions. Midwives stated that they would screen for bipolar disorder if there was a validated tool. There is, it's the MDQ, and that they are most familiar with the EPDS tool and are interested in more education about bipolar disorder management, screening options, and medication safety. 50% of participants reported having no formal education regarding bipolar disorder. This is unfortunate, and this is something that I unfortunately can relate to. I really wish that we had discussed mood disorders, particularly bipolar disorder and other less common ones than depression. And so I think by integrating these things into our perinatal mental health education, we can improve outcomes overall and be creating new midwives who are already equipped with these tools from the get-go instead of having to go back and learn this information. Okay, so this is just one snippet of my survey results, looking at screening for bipolar disorder and depression prenatally and postpartum. So on the left here, we have prenatal depression and bipolar screening practices, and there's a very stark difference. As you can see, almost 68% of people are regularly screening for prenatal depression, but only 7% of people were regularly screening for prenatal bipolar disorder. 73% never screened prenatally for bipolar, but only 10% never screened prenatally for depression. So moving to postpartum, almost 95% of midwives were regularly screening for postpartum disorder or postpartum depression, and almost nobody reported never screening for postpartum depression. On the converse, almost 79% of midwives taking the survey reported never screening for postpartum bipolar disorder. So we're comparing 0% versus almost 79% here. That is a really big difference and a really easy gap we can address just by administering one extra screening tool. It only takes a couple minutes. So based on the survey results and my literature review, I created a curriculum to educate midwives about perinatal bipolar disorder and reduce the stigma associated with bipolar disorder. Many of the things I talk about in it, we have gone over briefly today. Something else I added in was referral and consultation guidelines for community-based midwives. Essentially, when do they need to see a counselor, a psychiatrist? When do they need inpatient care? That sort of thing, as well as just more information about all the topics discussed. It's a 3 to 4 hour long curriculum. I also created 3 handouts for participants and made 5 case studies that I go throughout it, and we'll be going over one of those today. And I also plan to apply this curriculum for continuing education units and teach it once I graduate. Before we move into the case study, I just wanted to go over the project's strengths and weaknesses, because I think it's important to be self-reflective. So the strengths of this project is that it is one of the few pieces of literature about perinatal mental health that focuses on an out-of-hospital midwifery practice. Most of them are looking at nurse midwives or OBs who are hospital-based. The other thing is that there's very good comprehensive subject coverage. Most of the studies and literature I found were only focusing on very small, narrow areas of perinatal bipolar disorder care and not the larger picture that my project has done. And finally, my project offers the opportunity to reduce stigma about perinatal bipolar disorder. The weaknesses or drawbacks is that the curriculum has not yet been tested for efficacy, so I don't know for sure that it will improve screening or mental health outcomes, and that in general, there is just a limited amount of literature about perinatal bipolar disorder to actually base the curriculum and thesis paper on. I think I had about 85 references in total, and it was pretty hard to find all of the research I wanted. Okay, so let's go through the case study, and I'll be reading off some paper here. So this client is named Elena. She uses she and her pronouns, 33-year-old G2P2. And she just had their second child with their practice 24 hours ago. So she does have a significant history of depression in her last pregnancy and postpartum, and was able to control it without medication per her preference. She experienced similar depression in this pregnancy, and her EPDS score at 36 weeks was a 10, so that's a positive screen, and reported no suicidal ideation. So you see her for her day 1 home visit, and she reports feeling much less depressed than she did in pregnancy. Her mood is normal and she's feeling blissful but exhausted. So at 5 days postpartum, you get a phone call from her partner, Michael, concerned about her behavior. And this is what he says. Hello, I just wanted to check in about my wife, Elena, as I'm feeling quite concerned. She is acting so strange. I've never seen her like this before and don't know what to do. It started with her not sleeping well, but I just thought that she was a little anxious about the baby. And then she started acting as though she was on top of the world. I couldn't get her to stay in bed yesterday, but I know she needs to because her body is still healing. She wouldn't hear anything of it and spent the whole day deep cleaning the house, often singing made-up songs or muttering to herself, but I couldn't hear about what. She also kept whipping her head around every few minutes and scanning the room like she was looking for something or heard something strange. Anytime I tried to talk to her about it or encourage her to rest, she'd begin screaming at me and telling me I didn't understand and that she would not be safe unless everything was perfect. I didn't know what she meant by it, but again, thought it could be anxiety about cleanliness. She wouldn't elaborate when I asked, just kept telling me I wouldn't understand. She seems so erratic and frantic, wants nothing to do with the baby, and is convinced that somehow someone is watching us from inside our home, like with a hidden camera, I guess. She still acts like she's hearing things, and she's absolutely torn the house apart looking for who or what is watching her. And sent our daughter to his grandma since I don't think he should be seeing this. Please help us. So you know this is abnormal, but you're not sure what's causing this. So you tell Michael that Elena should be seen immediately. You call ahead to the emergency room to let them know she's coming and fax her records, and advise Michael to let you know if she won't go in on her own, or and then you can brainstorm ideas together or call 911 if needing extra support at that point. So he calls you back a few hours later. And he says, "I'm so sorry to bother you again, but I just couldn't get her to go in. I didn't want her to be traumatized by being forced to go to the hospital, but now I fear things are continuing to get worse. She's starting to mention throwing herself off a bridge or jumping in front of a car to escape whoever is supposedly watching her. I don't think she's safe anymore." So of course you instruct Michael to immediately call 911 and explain that this situation has become quite urgent now that she is expressing intent to harm herself. You get a call from a psychiatry ward 3 hours later, and they let you know that Elena was hospitalized and is suffering from postpartum psychosis. They explain that she must have had undiagnosed bipolar disorder. They give her medication to stop the psychotic episode, and she will have to remain on it to maintain stability. You speak with Michael on and off over the next few days. He has good support and is able to get donated milk for the baby. After a week of stability, Elena is discharged home. She feels quite shaken, depressed, and embarrassed about her behavior. She takes her medication as prescribed, but is devastated about the diagnosis. She sees a counselor twice a week for symptom monitoring and emotional processing. Her milk dried up during her inpatient stay, and her bonding with her baby was impacted. Over time, she regains her self-confidence, continues to heal emotionally, and comes to terms with what happened to her. She joins a support group with other parents who have suffered from postpartum psychosis. Eventually, she bonds again with her baby, and life feels normal again. So, takeaway or lesson of this case study is that postpartum psychosis is a psychiatric emergency that must be addressed immediately, and without screening, sometimes this is the first indication of bipolar disorder. So you might have noticed in this case, there was no bipolar screening done, but there was a positive depression screen. And it makes you wonder, if we had done a bipolar screening, would we have caught that this client had bipolar disorder and had been able to help her, or better let her and her partner know what to look out for as far as a psychotic, manic, or hypomanic episode goes. So finally, I just wanted to review my ideas for moving forward as far as perinatal bipolar disorder care and research goes. I think research to validate the PMQ, the Patient Mania Questionnaire, would be really useful, as well as research about the impact of educating midwives about bipolar disorder on mental health outcomes and the incidence of bipolar episodes overall. Finally, just a larger study of midwives' attitudes about perinatal bipolar disorder and their screening practices. My study did this, but it was quite small, really more of a survey than a study. And I think it would be good to look at this in a larger scale setting. Finally, for the future of the curriculum, I do want to teach it yearly and offer continuing education units. And I also want to offer sliding scale or reduced rates so that it is an accessible course. I believe that every midwife deserves the proper education to serve every client well, and this includes the mental health realm. And that's my presentation. Thank you all for listening, and I would be happy to answer any questions you might have.
Wonderful. Oh, yeah. Have everybody just get off mute for 30 seconds before we, and just to give her a round of applause and make some noise. Yes, thank you. And also, I would like to acknowledge again her committee members, and just the I think Dr. Amrita Bhatt is here, and if we could give her some applause for working with Marlee over 2 years. Marlee, I can't see. Is your other committee member here?
No, I didn't see Lori, unfortunately.
Okay, well, good. We'll just thank her in absentia. Our committee members are folks that the student reaches out to and volunteer their time over the 2-year process of the work. And so we at the Department of Midwifery are truly grateful for those folks who give of their expertise and time to our students. And so with that, I'd like to open it up for questions. Oh, Christina, go ahead.
Hi, everyone. Sorry, my video is not working. Marlee, thank you so much for this very educational and interesting presentation. I think I can recall from your presentation that you mentioned that the MDQ was not validated in a perinatal population.
No, it is validated. The other one, the PMQ, is not.
Okay, so I was thinking in terms of next steps, would you recommend perhaps that someone take on the validation of that instrument? Would that be helpful, or is the MDQ sufficient?
I think it would be really important for the PMQ to be validated. That is one of my recommendations for future research, simply because that is a current screening. So it's able to assess if someone is having a hypomanic episode right now, instead of the MDQ, in which it assesses have they had one before. So yeah, I think it would be really important to validate that one.
Awesome. Thank you so much. This is very important, in terms of what we can recommend future students in the midwifery and in the maternal and child health systems program to take on as their thesis or capstone projects. Thank you so much.
Yeah, thank you.
Thank you. Andrea?
Hi, Marlee. Thank you very much for this. I was a community midwife for 22 years and I never encountered anything like this in my education. And in my most of those years of doing exactly what you found, which is not screening people, and when they self-reported, not really knowing what to do, I do have a N of 1 where a woman decided to take herself off of lithium in pregnancy, and then was ever hopeful that placenta medicine would be would fill that gap for her postpartum, which it absolutely did not. And it's hard to know, because it's hard to know for her, but she thought it actually made it worse. I wonder if you encountered, I know you couldn't find it in your literature, but I wonder if you found it in your survey of people trying placenta medicine.
I do not recall hearing that. I definitely can see why someone would do that. I've definitely heard anecdotally that it could have mood benefits, but there isn't much research on that either. But yeah, that's really interesting, and it makes sense to me why someone would try it. I just didn't hear about that personally.
I guess you don't have any data to support it, but in your curriculum, I guess I might recommend drawing a link between, just like midwives and midwifery clients are inclined to put in natural sort of broad depression equivalence, that it's probably not the appropriate clinical picture to be trying those remedies.
Absolutely. Thank you.
Thank you very much.
I see Kristen had a question in the chat.
Oh, Kristen, are you still have service? She was actually in a place where she was afraid she might drop off. So I think we might have lost her momentarily. So Marlee, could you talk a little bit about the, sorry, Natalie's gonna read the question. Lucy. Oh, I knew somebody had one. Okay.
Kristen's question is, which, if any, tools are validated in diverse populations?
None is the answer, unfortunately. The ones that I mentioned were validated perinatally, so for the pregnant or postpartum population, but that's it. Nothing more specific than that, unfortunately.
Okay, all right. And Marlee, could you talk a little bit about the length? You talked about how you would like to offer the training and but how long do you think that you can do the 5 case studies? And because in just a half an hour, we know that you only scratch the surface. So if you could just talk a little bit about the length of time that you think it'll take.
Yes. I spent some time going over just the 5 case studies and timing it, and that took me about an hour and 10 minutes. So a third to a quarter of the final curriculum would consist of case studies, which is something I really considered. Is that too much? But I think that like hands-on interactive learning is very helpful and important, because in a setting of just midwives, it would be a lot more interactive, me asking questions, what do you think you should do, or what would you do in this situation, and then actually revealing what happened in the case study.
This is Britt. Hi, Marlee.
Hi, Britt.
Hi. So I guess I actually have 2 questions. First of all, is your opinion that every time that we're screening for depression or anxiety that we should also screen for bipolar, even like I know that the MDQ is a lifetime sort of screening tool, so should that be used multiple times prenatally or postpartum?
Yeah, good question. I would absolutely recommend administering some sort of depression screening tool when you screen, or some sort of bipolar screening tool when you screen for depression. If someone does not have a history of bipolar disorder, you could do the mood disorder questionnaire. But if they're already known to have it, it's frankly useless, and you should administer the PMQ, the patient mania questionnaire, assessing for current hypomanic symptoms. So in short, yes, I think we absolutely need to be screening every person for bipolar disorder, because otherwise we're very likely not going to catch it. And this is a time when people have such good continuity of care that we have this opportunity to provide it to them and to access this information for them so they can be best supported.
Awesome, thanks. Yeah, I guess I was partly wondering like if the MDQ should be administered multiple times, like right. If they screen negative, then would you administer it again postpartum, basically I guess to see if they had any of the like new symptoms during pregnancy?
Right, I would say likely not. If you were wondering if someone was symptomatic and had already given them the MDQ, I think it would be better to do the PMQ. Just repeating the MDQ likely won't reveal a whole lot more between a couple months time, although it may. I just think it would be better suited using like a current symptom tool in that case, if you've already screened someone historically, if that makes sense.
Yes, that makes sense, thanks. My other question is kind of along the same line. So as I know you're familiar with the fact that it's really hard for people to get in to see a counselor or like any type of mental health professional right now, and to like long waiting lists. So I'm curious if you have any thoughts on how urgently somebody should be getting in for a diagnostic evaluation if their MDQ is positive, and maybe if it depends on like if you also give them the, what is it called, the PMQ?
Mhm.
Then obviously if that was positive, maybe more urgently. But
Right. I think it's like so individual because bipolar is such a wide spectrum. There are people who can have very mild cases of hypomania from like severe cases of full-blown mania that they're not functioning normally at all. Same thing with depression. It can be mildly bipolar depressive or severely bipolar depressive to the point where they're suicidal. So I think that definitely comes into play is like, how is this person acting? Are they safe or are they not? And how soon do they feel they need to seek care? Because sometimes people have a preference, but ideally sooner is better rather than later, simply because we know bipolar disorder is neuroprogressive. So the longer it's untreated, the worse it can get. So giving our clients opportunities to learn that and be counseled about medications by a prescribing provider will help them to make those decisions in a timely fashion if need be. And I think telehealth is a really excellent tool that we can utilize, especially right now in a pandemic, since it is so hard to get in and resources are limited, especially in more rural communities.
so true about telehealth. Yeah, thank you so much. Your presentation was amazing, Marlee, and I expected nothing less.
Thanks, Britt.
Marlee, there's also Augustine Colebrook would put in the chat. She'd like to get a hold of you to do a podcast. So you might want to respond to her. And Kristen also had a question about are you going to, how can people read your paper? How can people access your paper? We know that it's going to be in the Bastyr Library in perpetuity, but do you have any plans for releasing it or distributing it?
Anyone who wants my paper can email me. I've considered publication, but it's quite a process. So that's still like in the brain. I think for now, I'd rather focus on really getting the curriculum ready to go and starting teaching it. So email me, I'll pop that in the chat, and Augustine, I will private message you.